네, 안녕하십니까. 남상치과 김기성 원장입니다.
Greetings, this is Dr. Kim Gi-sung of Namsang Dental Clinic. Today, I would like to introduce you the implant systems as part of our master course. Ostem offers a wide range of implants. There were 4 existing main implant systems: TS, SS, US, and MS. They were used most widely. Recently, KS implant was introduced, which stands for Key Solution. This has a strengthened connection and is receiving a lot of attention. When categorizing implant systems, there are 2 body implants where the implant and abutment are separate, and 1 body implants used where vertical and horizontal space is limited, especially in the lower anterior region, like the MS implant. The narrow implants can be used for overdenture and provisionals, but personally, I do not think they're very efficient. Depending on the connection, when we divide the implants, there's TS, and although it looks similar, KS, SS, and US have different connections. As you all know, the abutment can be divided into internal type and external type, which has been used from long time ago since the Browning mark implant times. These days, we use internal type primarily, and TS implant with 11-degree taper is used most frequently. The KS implant, which has been released recently, has 15-degree taper. So SS implant, which stems from Straumann implant, it has 8-degree Morse taper angle and it has internal connection. If you look at internal connection type, there are different taper as well as octa or hex connections. It can be divided into hex or octa on the indexing function, which is related to implant positioning. It may differ depending on the manufacturer, and we can divide depending on the angle. Let's take an overview of different implant systems. This is a TS implant system, which is used most widely. It has 11-degree taper, and it has about 1.2 millimeters of surface. There's hex below. The diameter of the hex is 2.5 millimeters in regular connection. This is a occlusal view of the actual implant. It has a stable connection and it is very easy to deliver prosthesis for this implant. Depending on the axis of macro design, it can be divided. It can be divided as 2, 3, and 4. 3 type 1.5-degree body angle option is used most frequently. There's also type 4 with a 6 degrees taper for areas with poor bone quality, such as in relation with the sinus. In the case of TS type 4, it's excellent for getting primary stability, but the surface area is reduced. Hence, TS3 is recommended in general cases. TS type is submerged type. However, one-stage surgery is done primarily. It has an internal hex with 11-degree taper, and the biggest advantage in using this is that there's less bone loss. The reason why it's used frequently is because it has less microgap, leakage, and micromobility, leading to less bone loss. I personally believe that TS implant is the best option for the anterior zone because you can adjust the abutment form and there's less bone resorption. This is especially because aesthetics are very important in the upper anterior zone. KS implant has similar form and it was released 3 years ago with a reinforced connection. Not many know about KS implant, so I would like to provide an explanation. If you look at advantages, various factors have been considered, and it has much stronger connection compared with TS implant. It has 15-degree taper. It's an upgraded version of TS. It looks very similar. The macro thread design, technically speaking, is the same. Length, specification, and diameter are mostly similar. Therefore, you can use the same surgical kit to place a KS implant. The only difference is the internal connection structure. The taper is 15 degrees and connection has become deeper. The diameter of the hex has become shorter. To give you an overview of the KS implant, it looks very similar to TS implant. The internal connection has been reduced and has become deeper. The thickness of different components have been increased to increase the strength of the implant. The difference between TS and KS is the angle, 11-degree taper and 15-degree, and there's difference in size of the hex. The biggest difference lies in the fact that as the length and width of abutment screw is reduced, the implant and abutment thickness have increased, leading to stronger connection. Strength has increased by about 4 times. Simply put, these area, KS implant has a thicker titanium outer wall. Various implants continue to show excellent results, but when placing 4.0 implant, I always choose KS because connection has been strengthened about 4 times compared with existing TS. There's no difference in implant placement process. Yes, different components have changed, so you have to have them in store. Apart from needing to have more options available in the dental clinic, there are many advantages to this implant, so it's becoming more widespread. The thread is the same, and the internal design has changed slightly. Among the different advantages, the biggest advantage is related to implant fracture possibility. It can prevent implant fracture, and the screw loosening has been reduced. The amount of settling down has been reduced as well, so there's less screw loosening. The connection area is similar to TS, so you cannot really tell the difference. The advantage in using KS is that it has unique bumps at the abutment space, allowing for one-handed management while adjusting the prosthesis, significantly enhancing the system's usability. Next is SS implant. Personally, I have mixed feelings about it. I used to use it very frequently, but as I started to use one-guide surgery, I use it less. It has the strongest connection. The problem is that it has machined surface in the neck area, so it's unfavorable to use in aesthetic zone, and it's quite unfavorable compared with TS in terms of handling prosthodontic components. It has internal octa structure. There's gingival thickness of 1.8 and 2.8. Platform diameter is 4.8 and 6.0. The 6.0 wide platform is used for posterior area. Regular platform 4.8 is used in other instances. The implant diameter ranges from 3.5 to 7.0. And the macro design is the same as TS. The only difference is the neck area. Because it has neck, it is referred to as gingival level implant or tissue level implant. There is a straight and tapered option, as is the TS implant. The taper is just up to 3 degrees and there's no 4. It has the same look as TS3 with 1.5 degree taper. The machined surface area goes to the gingival side. If possible, this implant should also be placed slightly deeper, and the abutment can be fabricated using CAD-CAM or Conocta Plus. As for SS implant, unlike other implants, the bevel area of 0.65 millimeters is in contact with the abutment or the prosthesis that goes on top. Hence, there's less sinking down and the connection is strengthened. However, if you place this implant deeper, you no longer can use the bevel as the margin of the prosthesis. Gingival cuff height is 1.8 and 2.8, and depending on gingival thickness, you can differentiate different options. If the gingival thickness is deep, if you use SS implant following the bone level, the bevel margin, which was advantage, can serve as disadvantage. In that case, you need to use Conocta Plus abutment. The gingival cuff is similar to that of cemented type abutment. The marginal position needs to be changed to deliver prosthesis. Personally, I believe this is the most fit option. The prosthesis type I use primarily is ER type, and this requires retrievability. If there is implant bevel, if there is issues with cement, then it will be a major problem. I either use Conocta Plus or one fit abutment for SS. The advantages of SS. This is non-submerged type. It has octa structure. The connection stability is outstanding, more so than any other implant system. Next is US implant. This is external implant. This basically signifies the early stage implants placed from 1965. Currently, it is used less than 10%, and such usage is decreasing. I don't think this connection is a bad connection, but the popularity of it has passed and it's being used less. It can lead to very good results when it is a multiple case. However, there are some difficulties in connecting healing abutment right after surgery compared with internal type implants such as TS. Various external height is available. The standard is 0.7 millimeter hex connection. There are many implants that use the same connection worldwide. This is US type because it is used universally in the past. I used to use this kind of implant primarily, but even 20 years past, it does not have that many disadvantages. These days, the trend is to place the implant more deep considering the simplicity of surgery and aesthetics. Hence, it is used less these days. Regarding joint, it has butt joint structure, so the surface of the implant and abutment are in contact. Abutment sinking down, which occurs in internal connections such as TS, frequently does not occur. As for external implant compared with the internal type, there's much more screw loosening. Based on my clinical experience, that's not really so. However, if there is a bone interference when connecting abutment and healing abutment, there can be difficulties. There's different implant hex size available. In general, 4 types of connection are available from Ostem: mini, regular, wide, and wide PS. PS stands for platform switching. Wide implant and hex size is 2.7 millimeters. This is PS. This is implant system for platform switching. US implant has connection projected to the outside, and it has butt joint where surface-to-surface contact is made. It's shown in green. You can get great prognosis using external implants when you use a screw-type prosthesis. When doing multiple cases using screw-type or ER-type, it has many advantages. However, it is being surpassed by internal type and the usage is going down. In lower anterior area, there's very limited mesiodistal buccolingual dimension. It is quite difficult to use two-piece type implant where implant and abutment are separated. The bone quality is extremely lacking. Ostom has produced a one-body MS implant. MS implant is placed by just drilling once or twice. Therefore, there can be issues with primary stability and failure rate is higher compared with other areas. Personally, I like to use MS implant in lower anterior area. If you master basic technique, you can get great clinical results. So for lower anterior, I strongly recommend MS implant. There's no abutment screw, and as shown, this is a one-body implant. Because it is very thin, it is made of alloy. This is the only titanium grade 5 implant, and this has SA surface. Although many people use that, I prefer RBM surface. It may differ depending on the surgeon. There are three options available. MS narrow ridge implant is for tooth replacement, MS denture is for denture, and MS provisional is used for provisionalization during osseointegration when multiple implants are placed. I hardly use these two options and I've never used this one. Please take note that implant and attachment are connected. This can be utilized as provisional, but for it to be used as final prosthesis, if the attachment is worn out, it cannot be replaced. So we need to factor these considerations in. In lower anterior, I use a MS implant quite frequently. If you look at the results, it shows quite high success rate. This implant requires drilling of just once or twice. If you make a mistake, you'll not be able to get primary stability, and this can lead to failure. In order to place MS properly, you need to use one MS kit. By doing this, you'll be able to place it in more precise position easily. MS implant has concave gingival cuff area. There is 2.5 and 4.0 option. As for young patient with congenitally missing tooth in the anterior zone, you'd end up with 2.5 option, but for elderly patients, I primarily use gingival cuff 4.0 and choose the right implant. There's implant diameter between 2.0 to 3.0. I primarily use 2.5 by 13 millimeter implant. This is what I use most frequently. I wonder whether this is necessary. The length is 8 to 13 millimeters. My preferred length is 13 millimeters. As for denture type, this is a ball attachment for overdenture, but once there's osseointegration, and if there is a wear on the attachment, there can be issues, so we need to consider that in. In multiple missing case, when we place implant, during osseointegration phase, we can use this provisional to restore masticatory function. Personally, osseointegration speed has accelerated, and by just placing 3 to 4 implants, you can provide the provisionals right away. So I rarely use this. MS implant has inclination. So there's inclination of 5 degrees. When you design a lower anterior bridge using these two implants, if the angle is about 10 degrees, we can provide prosthesis without problem. But if it goes beyond that, there can be issues in providing abutment. So when placing implants, we need to use guided surgery so that they're placed in parallel, especially when providing bridge-type prosthesis. Because you cannot choose ER-type prosthesis for this implant, you need to choose cement type. The dimension is extremely lacking. In my case, I do not believe it is fit to use a zirconia. It can become too fat. When placing MS implant, I use a PFM prosthesis. Today, I've briefly introduced different implant systems. If you're interested in specifics, please come to the offline master course planned for February next year to get more in-depth knowledge. I hope to see you there. You'll be able to get significant knowledge and information as to how to use different implants. You'll be able to choose the right implant system which lasts longer. Today, I've briefly discussed upon this topic. I hope to see you in offline course. Thank you.